All right, good morning, everyone, and thank you so much for joining us for Screening and Treating Chlamydia in Primary Care for our webinar this morning. This webinar is part of an ongoing public health and primary care webinar series featuring public health experts who offer valuable training and resources to primary care providers and their teams with ideas and examples of how the two can work together to improve population health. Before we turn things over to our expert, I just want to review a few things about the technology we're using today. Everyone on the line is and will remain on a global mute throughout the presentation. However, we do have several opportunities for you to submit your questions and for us to get you feedback. We welcome you to submit questions at any time through the question pane on the right side of your screen. You can type them away and then I will sort through them and try and group like questions to the best of my ability. We also will, at the very end of the presentation, have an opportunity if you would like to verbally clarify your statement. You can raise your hand. That's also an icon to the left of your name. And we will be able to unmute you if you are unmuted. So barring technology, that should be an option for you. If you have any technical issues throughout the presentation, again, do please feel free to submit those through the question pane as well. Also, before we get started, a few quick words about the Patient-Centered Primary Care Institute that is hosting this webinar. The Institute is a public-private partnership launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation. It is currently managed by Oregon Healthcare Quality Corporation, for which I am an employee. My name is Rebecca Bally. I'm a Facilitation and Improvement Specialist here. And together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. We work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to visit our website at www.pcpci.org to access resources, including previous webinars. And you can sign up for our email list on the website, which is how we will announce additional web-based and in-person training opportunities, as well as future Institute programs. And as I mentioned, the Institute aims to help primary care practices achieve recognition as a primary care home through Oregon's Patient-Centered Primary Care Home, or PCPCH program. The model is a set of standards organized under 6 core attributes, which you see here. You can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. And finally, I am pleased to introduce our expert speaker today. Dr. Sean Schaefer has been a medical epidemiologist and public health physician with the Oregon Health Authority HIV, STD, and Tuberculosis Program, HST, since 2005. He manages HIV surveillance, medical monitoring project, supplemental surveillance for HIV cases in medical care, the National HIV Behavioral Surveillance, and human papillomavirus surveillance in Oregon. He serves as medical director for Oregon's HIV prevention, STD control, and tuberculosis section. From 2003 to 2005, he was an epidemic intelligence service officer with CDC assigned to Oregon. Formerly, he was a family physician in California and worked as a staff physician in community health centers and as a faculty member with the UCSF Fresno Family Practice Residency Program. In addition to his role with the HIV, STD, and Tuberculosis Program, he has co-sponsored development of Oregon's integrated electronic disease reporting system, worked on health information exchange, edited the Oregon Health Division biweekly publication, CDD summary, and worked on pertussis, intimate partner violence, hepatitis A, and foodborne disease outbreaks. Clearly, we have a fantastic expert at the helm today, and I am so pleased to turn things over to you, Dr. Schaefer.
Thank you, Rebecca. Good morning, everyone. My goal is to convince you to seek to acquire 3 habits. I think I'll allow you to be maximally effective at preventing chlamydia and reducing its impact. So our learning objectives describe 3 important primary care activities to control chlamydia and reduce infertility. Those being screening, expedited partner therapy, and retesting everyone who is treated for chlamydia. Before discussing these, I'll briefly review the biology, treatment, and groups at most risk of chlamydia and the size of the problem. Chlamydia is an intracellular bacterium. Incubation, or the interval from exposure to symptoms if they develop, is 14 to 21 days. Chlamydia infects women and newborns and is easily transmitted to sex partners. It can affect the throat, urethra, rectum, cervix, and internal reproductive organs. Chlamydia doesn't usually cause symptoms. 70 to 90% of women and 40 to 90% of men have no symptoms, making screening the primary means of recognition. Complications include pelvic inflammatory disease, tubal infertility, ectopic pregnancy, chronic pelvic pain, and in men, epididymitis. Chlamydia is the most common cause of tubal infertility. Nucleic acid amplification, or NAT tests, are used for testing. Culture can be done, but it's rare these days, and NATs typically detect 20 to 50% more chlamydia infections than cultures. NATs can be done with urine or urethral, vaginal, or cervical swabs. Self-collection of vaginal swabs in the office is FDA approved for several of the available NATs. Rectal or pharyngeal swabs can be tested if your lab validated. Locally, Providence and Peace Health Labs indicate that rectal and pharyngeal swabs are acceptable. Quest and Kaiser don't list these sources as acceptable on their website, so you'll need to check with your lab. In addition, testing for chlamydia and gonorrhea is often bundled, meaning that if you request one, you get both, because they're usually done simultaneously on the same laboratory equipment. For women, vaginal swabs are actually more sensitive than cervical swabs. First catch urine is acceptable for screening, but detects about 10% fewer infections. For men, first catch urine is equivalent to urethral swab, so you can spare the rod and save the child here, if you will. If you want to test pharynx or rectum, remember to check with your lab to make sure they can test specimens from those sites. Treatment cures chlamydia, so the recommended treatment is azithromycin 1 gram once by mouth. Ideally, the provider can observe the patient swallowing the medicine. Alternatively, doxycycline by mouth twice daily for 10 days can be used. Fluoroquinolones work too. Resistance is almost unheard of. Repeated positive tests are almost always caused by reinfection or failure to take the treatment as recommended. Chlamydia is the most common reportable disease in the U.S. and in Oregon. Healthcare providers and laboratories reported over 15,000 cases in Oregon during 2015. Oregon rates overall tend to be about 350 to 400 cases reported per 100,000 and about 20% lower than the U.S. rates. So that translates to about 4 reported cases per 1,000 people. But reported cases represent only a fraction of all cases that actually occur. In some age groups and some communities, as many as 15% of the population has chlamydia at any one time. This is a picture of Dallas, Oregon. It has just over 14,000 residents, just about equal to the number of cases reported in Oregon during 2013. So if you're from Dallas, Dallas is a nice place, and residents there aren't any more likely than other Oregonians to get chlamydia. But sometimes it's helpful to have a real-life comparison to best understand the size of the problem. This chart indicates cumulative reported cases of chlamydia over the previous 10 years. by age group and sex, with men indicated by the blue bars and the women indicated by the orange. About 80,000 cases were reported in men and women aged 15 to 24 years during those 10 years. Rates in these age groups are approximately tenfold higher than 4 per thousand cases in the general population. This chart now represents chlamydia prevalence among sexually active women in the U.S. by age on the left and race or ethnicity on the right. Prevalence is highest among women aged 14 to 19 years. I think I have a pointer. Probably this one. Let's see here. No, laser pointer, yeah. So prevalence is highest in women, sexually active women aged 14 to 19. About 6% of the U.S. population is infected. This declines with age until women aged 25 to 39 are about a fourth as likely to have chlamydia. So by race, about 1 in 7 non-Hispanic black women aged 14 to 24 years have chlamydia at any time, and chlamydia is about 7.5 times more prevalent than it is among white non-Hispanic women, among whom 1 in 55 are infected. Well, now the problem is advancing my slide. Let me see here. There we go. Though this slide reflects data from 2012, chlamydia rates in Oregon among black or African American persons exceed reported rates in whites by approximately 4-fold. 516 million is the estimated annual direct medical cost for all cases of chlamydia acquired in the U.S. during 2008. This doesn't even include the cost for screening, ectopic pregnancy treatment, tubal infertility, chronic pelvic pain, personal costs of attending the clinic, lost productivity, or pain and suffering. Okay, let's assume you're convinced chlamydia is a sufficiently big health problem for you to want to do your part to reduce it. So what should you do? Cancel Chlamydia Palooza? Maybe promote it. So I recommend 3 primary care habits. Screen appropriately for chlamydia use. Use expedited partner therapy liberally. And collect a repeat test for chlamydia 3 to 12 months after treatment from everyone you treat. One paper, now 20 years old, compared universal screening to no screening and concluded that universal screening was cost-saving when the prevalence was at least 6.6%. Cost-saving means that screening actually reduces overall costs related to the disease even after accounting for the cost of screening and treating all the additional cases identified by screening. And screening remained cost-effective when prevalence fell to as low as 3%. Note that, unlike others, this group did consider less tangible indirect costs such as lost productivity. Frequently, cost-effectiveness studies restrict cost considerations to tangible direct medical costs. If they'd done this, the screening would likely appear less effective. But I discuss this paper because CDC's recommendation for screening frequently encourages screening in populations where prevalence exceeds 3%. U.S. Preventive Services Task Force, American Congress of Obstetrics and Gynecology, CDC, and American Academy of Family Physicians have similar recommendations. Pick one and follow it. All recommend screening high-risk women, regardless of age, including women with multiple partners, new partners, inconsistent condom use, concurrent use of alcohol or drugs with sex, and sex in exchange for money or drugs. All recommend screening all sexually active women regardless of risk through age 25 except for the task force, which would have you stop at 24. They all recommend screening in communities where prevalence is high, though they've left the threshold to your judgment. I'd say if you believe prevalence is higher than 6% in any particular community, you ought to screen in that group. So pregnant women should also be screened. CDC and ACOG say to screen all pregnant women. The task force and AFP say to limit screening in pregnancy to high-risk women and women who belong to high-prevalence communities. Men who have sex with men and people with HIV should be screened at least annually and up to every 3 months if risk is ongoing. CDC, but not the task force, recommends screening men in high-prevalence settings. Unfortunately, none of the groups offer recommended intervals for screening, though many would say that annual is prudent, and more often if risk factors are ongoing. So does screening actually reduce complications? About 15% of women with untreated chlamydia will develop pelvic inflammatory disease, but only about 40% of those PID cases will be symptomatic. Ectopic pregnancy occurs in 5 to 10% of women who have had PID, tubal infertility in 10 to 20%, and chronic pelvic pain in 15 to 20% of women who have had PID, regardless of whether that PID was symptomatic. Screening reduces infertility at the population level. So this is from the National Survey of Family Growth. It shows a percentage of U.S. couples reporting infertility on the vertical axis, defined as a lack of pregnancy during the previous 12 months despite unprotected intercourse. And that declined over the decades when the role of chlamydia in infertility became understood and screening became more prevalent with treatment. Increased screening also coincided with declines of diagnosed pelvic inflammatory disease at Kaiser Permanente Northwest between 1997 and 2007, where screening among sexually active women increased by 25%, and diagnoses doubled, but PID actually declined by half. Ectopic pregnancy rates are difficult to measure because there's been a shift in the last several decades from hospital to outpatient care for the condition, and it's difficult to count discrete episodes using claims data. Nevertheless, investigators from British Columbia reported that hospital rates of PID, ectopic pregnancy, and tubal infertility all declined in the era of chlamydia screening. So how much screening is happening in Oregon? Well, apparently we have plenty of headroom for improvement. This graphic is from the Oregon Medicaid billing data and depicts chlamydia screening among enrolled sexually active women aged 16 to 24. About 60%, which is still below the benchmark, were screened in 2011, and this proportion actually fell to 54% in 2013. So how can you acquire the screening habit? Well, setting benchmarks for practices in health systems is one effective way to approach this. For example, screening sexually active women for chlamydia is a statewide performance measure for Medicaid. The goal is 64%. In theory, if the Medicaid system fails to meet this, then OHA pays a penalty to CMS. Incentives include monetary and other types. Coordinated care organizations have incentive measures in Oregon. If they meet the goal, they get additional dollars. If though it's a performance measure for OHA, and OHA pays a penalty to CMS if it's not met, chlamydia screening isn't an incentive measure for CCOs, so something to consider. Safety net clinics like Planned Parenthood, school health centers, and federally qualified health centers can also qualify for subsidized chlamydia testing done at Oregon State Public Health Laboratory. However, this is not available for most healthcare settings, but you should contact the OHA's Sexually Transmitted Disease Program if you think your setting might be eligible. Systemic screening reminders such as electronic medical records, like smart sets, and other reminders that are programmed into electronic medical records can also be effective. And then routinely scheduling adolescent health visits where chlamydia screening is done systematically can help. Also, patients can use apps and other tools to remind them to test. For example, OHA offers Oregon Reminders, which was originally built to remind people to get tested regularly for HIV or to take HIV tests. It's also available for free for any sort of reminder. It will text or email you with any message you set at whatever interval you set. So one strategy to increase screening would be to help young men and women sign up for Oregon Reminders before leaving an appointment, and then setting a reminder to get another chlamydia test in a year or sooner, if indicated. If they want to use a special message to conceal the true meaning from others with prying eyes, then they can do that too. I think it's an opportunity for questions, Becca, yeah?
Yes, yeah, a first opportunity for questions. Any questions that folks have about that first good habit of screening, or even about the general information about chlamydia. There was actually a question and concern about some of the statistics around prevalence and whether or not is it possible that we aren't testing white women and men at the same rates that we are testing, or screening rather, African American and Hispanic women and men?
Yeah, it's very likely. Actually, I've seen data in the past that suggest that very thing. So that might actually be part of the reason for the relatively higher prevalence in that group. For some reason, physicians, clinicians, others are more likely to screen women of color and men of color than whites. I don't think that accounts for the entire difference, because we know that many infectious diseases are more prevalent among people of color, and you know, many of those diseases aren't diseases where you'd see a screening artifact like you might with chlamydia. So yeah, good point. We certainly have lots of headroom for screening, and that's true for all races.
Sure, lots of room for improvement. There was another question that somebody missed the rate of infertility following pelvic inflammatory disease. They just missed the number. Could you remind us what that was again?
Yeah, let's go back to that slide and just look at it again, okay? It's easy enough. I think we have time. So, first of all, chlamydia is the largest single cause of tubal infertility in the U.S., which is a good emphasis of the question. So that's actually what we're trying to affect, that and ectopic pregnancy and chronic pelvic pain. Lots of chlamydia doesn't cause symptoms, so were it not for these other complications, we might not be as concerned. So as I was saying at the time, about 15% of chlamydia will result in PID. That would be untreated chlamydia. But most, or at least almost half of that PID is not going to be symptomatic, so you won't be aware of it. And in those women who get PID, then ectopic pregnancy about 5 to 10%, tubal infertility in 10 to 20%, and chronic pelvic pain in 15 to 20% of women who had PID, regardless of whether the PID was symptomatic. So these are really big problems in primary care, and a lot of them are attributable to chlamydia, much of which might have been asymptomatic.
So thank you for going back to that slide. Two more questions, and then we do need to move on to the next two sections.
Sure.
But you talked about the Oregon reminder system, and somebody was wondering if it was possible for HCP offices or local health departments to use this reminder system for their patients.
Anyone can use it, and I would encourage you to do that. I'm not myself familiar with them. I'm not the best user of smartphones, but I know that there are reminder apps that are out there that that your patients might be aware of, and they can certainly use those too. But OHA built Oregon Reminders originally to remind people about HIV drugs, and it has over I think over 1,500 subscribers who use it for that purpose. But it's also used to remind people to get syphilis screening, chlamydia. I mean, you could use it to remind you to go to the grocery store if you wanted to, but it's, you know, it was set up to remind people to get disease screening and remember to take their medicines. They can use it to remember to take their high blood pressure medicine. We don't know what they're using it for, so please do. That's what I was hoping to encourage.
That's a great resource. I'll make sure that we put that link in the chat,
Sure.
and then the link is also in the slides that are included.
Yeah,
in the
sure.
chat.
Yeah,
and then last question before we move on quickly is, should you do pharyngeal screening for chlamydia?
Right. Well, actually, CDC doesn't recommend pharyngeal screening, and usually pharyngeal chlamydia infections don't cause symptoms. However, pharyngeal infections can be transmitted sexually. So if you diagnose a pharyngeal infection, you should treat it exactly as you treat infections of the rectum or urethra or cervix. Okay, should we go on?
Yep, we're ready to move on. Thanks.
All right. All right, so we're on our second good habit. Expedited partner therapy is antibiotic treatment of the sex partners of people who have sexually transmitted infections without doing a medical exam on the partner. Expedited partner therapy is also called patient-delivered partner therapy. It's simple. The provider who diagnosed a chlamydia or gonorrhea infection or either directly gives the medicine to the patient that's infected, intended for the sex partner to take, or the patient delivers the medicine, or the provider gives the patient a prescription that the patient then delivers to the partner to fill and take. 2015 guidelines, CDC recommended EPT for chlamydia or gonorrhea when a provider can't be sure that all partners will come in and get treatment in the traditional fashion. So frankly, this probably includes most cases. For chlamydia without gonorrhea, use azithromycin 1 gram by mouth 1 time. For gonorrhea with or without chlamydia, use cefixime 400 milligrams by mouth once, or cefpodoxime 400 milligrams by mouth once, plus azithromycin 1 gram by mouth once, regardless of whether cefixime or cefpodoxime is selected. Expedited partner therapy for chlamydia or gonorrhea is entirely legal in Oregon since 2009. In that year, Oregon's legislature created a law enabling health professions boards to adopt rules that permit EPT prescriptions to be issued without a name. OHA was required to determine which diseases are appropriate and create informational material, which it did. Subsequently, Oregon Medical Board Statement of Philosophy included a section on EPT in which it endorses as the only reasonable approach to successfully treat partners. Oregon Board of Nursing prescribing guidelines permit expedited partner therapy via an exception to their prescribing rules. And the Board of Pharmacy's regulations permit pharmacists to fill prescriptions that are written for EPT, even if a name is not included on the prescription. The same rule permits dispensing facilities to dispense medicines directly for EPT without a name. So the medicine can be directly dispensed for the patient, for the partner, if the clinic has its capacity. Most in Oregon don't. Some do, though. The provider can write a prescription in the name of the partner, if it's known, or in the name of the patient, with an indication that the prescription is for the partner. So Jane Doe dash partner or Jane Doe dash EPT partner. If the partner's name is not available or not divulged, the prescription has to clearly indicate for EPT. Some settings create partner packs for this purpose. Again, in some states this is more prevalent, less so in Oregon, but it does exist. Commonly in Oregon, a provider writes a prescription for a patient's partner, and pharmacists should then fill it if it includes the for EPT statement, and again, patient's name and dash partner, or you can put the partner's name in here. It's always helpful, I think, to put for EPT. Some pharmacists still aren't familiar, and if your pharmacist isn't familiar, then you should send them to the OHA website, which they can get to by Googling Expedited Partner Therapy Oregon. It has frequently asked questions, procedures for expedited partner therapy, and information for pharmacists to reassure them about the legality of filling those prescriptions. You can also find brochures in both English and Spanish to print out and use. You're free to have somebody with graphic art skills in your practice adapt these for local branding. More information available at our site, and the easiest way to get there without giving you a 10-mile long URL is APT Oregon with Google. So at present, Oregon Health Association advises limiting APT to gonorrhea or chlamydia if in-person testing and treatment isn't likely to happen for the partner. Actually, that if people are honest, applies to a lot of cases. So avoid using EPT in pregnant women and with men who have sex with men. Consider EPT for all sex partners within the last 60 days, but if the patient doesn't disclose or denies partners in the last 60 days, you should try to treat the most recent sex partner regardless of when that was. Use instructional materials for the partner such as those provided on the OHA website. Ask the patient to abstain from sex for 7 days after treatment, and then recommend repeat testing for chlamydia after 3 months for everyone who's diagnosed with chlamydia. Some of you might ask why EPT is necessary. Well, the problem is the size of the problem. With over 15,000 reported cases of chlamydia each year, 45,000 actual chlamydia infections, 5 to 10% of sexually active adolescent females infected, and up to 85% of cases being asymptomatic. And then, after treatment, 15 to 30% of infected young women become reinfected within 6 months. So, primary care providers have to be involved to help screening and treating as many partners as possible, and to conduct regular retesting. Public health resources aren't even sufficient to count the cases, let alone find the partners and assure their treatment, and then make sure that people get reminded to be tested. Nationwide, approximately 1 in 10 women diagnosed with chlamydia might receive help from the public health department to notify and treat their partners, but this number is pretty old, and it's probably quite a bit less now. The numbers of chlamydia have just made that almost impossible. About 65% of STD patients report untreated partners if they're asked to refer their partners for testing and treatment, and only half of the partners of patients with gonorrhea or chlamydia actually receive treatment, and I think that's optimistic in settings where EPT isn't used. Expedited partner therapy reduces reinfection. So this chart shows reinfection at 3 months among people given standard care in gold, so standard care, and EPT in red. The rightmost grouping shows combined reinfection rates for gonorrhea or chlamydia. On standard care, 13% of participants were reinfected at their 3-month follow-up, but only 10% of expedited partner therapies were patients were reinfected. So this might seem like a small reduction, but it's about a 25% relative reduction in the number of reinfected patients, and given the large numbers of chlamydia that we're dealing with, this represents a huge reduction in chlamydia impact across the population. In addition to reducing rates of reinfection, EPT increases notification and treatment of partners. So just the act of suggesting expedited or providing medicines for partners actually results in those partners getting notified. So in these 3 studies, partners were anywhere from 10 to 90% more likely to get notified and treated than when standard recommendations for partners to get tested were used. So relatively little literature has been published on strategies for increasing recommendations and uptake of APT. The following approaches have some support in the literature. So offering free medicines is great if it's possible in your setting or through your pharmacy. Now this is available to some settings in some pharmacies. We certainly recognize that not everybody has the opportunity to offer free meds for partners. Again, if it's possible, providing those meds on site in lieu of a prescription likely enhances the uptake or use of EPT because it's one less step to getting the medicine in the partner's hands and ultimately swallowed. It helps to get written prominent support from the clinic medical director, and it helps to develop written policies for your site, including all plans and materials necessary for provision of APT readily available in all areas where providers might be diagnosing chlamydia or gonorrhea. It's great if you can to talk with the pharmacies that are likely to be filling your prescriptions just to make sure they're familiar with the rules and that they might be seeing prescriptions from you for APT that will look a little confusing if it's not something that other providers in your community have been doing regularly. It's also useful to offer to talk on the phone with the patient's partners if that's possible, and the patient wants you to do that. It's good to remember to tell those partners that taking the medicine will help prevent complications of these infections in both partners. And another thing to remember, as we talked about from the beginning, chlamydia is typically an asymptomatic infection, and gonorrhea can often be asymptomatic as well. So it's good to remind those partners that it's impossible to tell who transmitted the infection to whom, and sometimes those infections can persist unrecognized for quite some time. So it's probably not a fruitful exercise to try to figure out whose fault it is. You can add a structured field in the medical record. That both helps measure the use of EPT, but it's also a subtle reminder for clinicians that it's something that they should be considering. Establish an APT-related quality assurance measure. So if you were to add a structured data field or you did something else to try to measure the frequency and the use of expedited partner therapy in your setting, you likely increase the visibility and you measure it in a way that enables you to increase the utilization. You can add reminders like smart sets to electronic medical records or pop-ups. You can the other thing to do is presumptively treated patients are actually kind of a barrier to APT, because what happens is that people will report an exposure to collect a test, and you treat them presumptively, but without a positive test, most providers would understandably be reluctant to provide expedited partner therapy for partners of presumptively treated patients. So then that patient leaves the clinic and they don't necessarily come back to pick up expedited partner therapy prescriptions. So strategizing about how to get expedited partner therapy into the hands of presumptively treated patients when their lab tests are positive is probably a worthwhile activity. We come to another question session. So Rebecca?
Yes. Thank you, everyone who's been submitting your questions. Keep them coming. We had a holdover question from the last section about how effectively does pharyngeal CT spread through oral sex to a female partner?
Yeah, I don't know numerically the answer to that question. The best I can do for you is it's possible. I can try to find more information about the relative likelihood of spreading it that way, but I don't know it off the top of my head. So appreciate the question, and well, I can try to get back to you through Rebecca.
Okay. Yes, and we can post additional links and resources on our website. Another question that came in was why the avoidance of EPT in men who have sex with other men?
Yeah, this question almost always comes up, and there are a lot of people who advocate using expedited partner therapy for men who have sex with men. In Oregon and in most places, we don't recommend it. That's consistent with CDC guidelines. The reason for that is pretty simple and a little bit frustrating, and that is that all of the literature and studies that have been done excluded men who have sex with men with regard to expedited partner therapy, primarily because the investigators were fearful of missed opportunities to make a diagnosis of unrecognized HIV or syphilis. Although there are no data to support or refute the use of EPT for chlamydia and gonorrhea in men who have sex with men, a lot of people advocate its use because a misdiagnosis of HIV or syphilis is probably going to happen whether or not expedited partner therapy is offered, and you miss an opportunity to treat partners and suppress the spread of those infections. So hopefully we'll have a more satisfactory resolution to that question. Similar kind of logic for pregnant women. We don't recommend it for pregnant women. Or if you use it for pregnant women, you should try very hard to get them and their partners in for follow-up because of the other issues related to the diagnosis of STDs in pregnant women.
Perfect. Yeah, thank you. That came up a couple of times in the question. So another question, slightly off topic from chlamydia, but there was a for EPT highlights in Oregon, said that you must have a gonorrhea or chlamydia diagnosis, and somebody's wondering about the possibility of future prescribed EPT for trichomoniasis.
Yeah, there's at least one that I'm familiar with. It's over 10 years old now, but at least one study where they studied trichomoniasis expedited partner therapy, and there wasn't a measurable benefit from expedited partner therapy. I'm sure some people do it. I think its effectiveness is still a question. So yeah, it's certainly come up and been studied, and some people probably still argue for its use, but it isn't officially part of the group of diseases for which we recommend it in Oregon, and I think Oregon's pretty consistent with, well, certainly consistent with CDC on that.
Okay, so maybe more studies. It sounds like more studies are needed to support some of the last few questions. But
yeah, certainly with, well, there have been studies with TRIC, and then the questions related to MSM, men who have sex with men, I think are still open, but aren't supported by strong clinical data yet, so still aren't part of the official recommendations.
Okay, and another question came up about pharyngeal screening again, and is it advisable for heterosexual men and women?
Well, screening the pharynx is, well, so first of all, the pharynx, infections of the pharynx usually aren't symptomatic, and their clinical significance is really not well understood. In other words, it's not clear that having a chlamydial infection predisposes you to getting PID and subsequent complications of chlamydia, for example. So the clinical relevance of pharyngeal infections is a little bit in question, which is why CDC and others don't recommend routinely screening the pharynx in men or women, regardless of their sexual orientation. However, it often comes up because men who have sex with men and women who have had oral sex exposures often get tested pharyngeal for gonorrhea, but those tests are bundled, so often chlamydia shows up in the pharyngeal test, and that should be treated. I would also say that you should look for pharyngeal infection in men and women who have unexplained repeat infections. As I was saying before, resistance is just not something that comes up with chlamydia, which is a lucky thing, but often you'll have frustrating cases where people seem to be getting reinfected and they've taken their medicines. So consider screening or testing. I guess it wouldn't be screening in that setting, but consider testing the pharynx in those settings. You can certainly test people who have pharyngeal exposure through sex usually, but in terms of routine systematic screening, it isn't something I recommend. I hope I actually answered the question.
I think you did, and you actually led into the last question that we have for this section about how long can someone conceivably have an asymptomatic CT infection without developing complications. So months, years. They said that patients often ask about this.
They do. They do ask about it, and I don't have a good answer. I've been asked about it many times. I read some of the old literature about this a while back, and it appears to me that people can have chlamydia infections for certainly up to a year and potentially longer, asymptomatic infections. So it's certainly something that that happens. I don't know how many people spontaneously clear at that length of time after exposure, but certainly there are people who can have infections that persist for longer than a year.
Perfect, thank you. And that's all the questions we have for this section, and we have about 10 minutes or so for the next section.
Should be fine. Should be fine.
Thank you, everyone, for your questions.
Ready? Okay. So let's talk about the third good habit. CDC recommends that all men and women who have been treated for chlamydia should be retested about 3 months after treatment, regardless of whether they believe that their sex partners were treated. If retesting at 3 months is not possible, then clinicians should retest whenever the person next presents for medical care in the 12-month period after their initial diagnosis. Unfortunately, this recommendation is followed in a minority of cases in Oregon. We actually know this from billing records from safety net clinics that were part of the infertility prevention program that officially ended a couple of years ago, but still is largely active. We had a lot of data from that that system, and unfortunately, only a fraction of people who were infected appear to have had retesting within a year. So this is a slide I showed earlier with data from one of the trials of expedited partner therapy. The yellow bars show the proportion affected again after 3 months under standard care. It's characterized by recommendations to advise the partner to get tested without IPT, and the red bars show the reinfection of those who did get EPT. The thing to notice here is that if you didn't get EPT, 13% of people were reinfected at 3 months, and even if you did, 10% were reinfected. So this is, well above the 6 or 7% prevalence above which screening is thought to be cost-saving. So retesting is not intended to test the effectiveness of treatment, or what some people sometimes call a test of cure, but rather you can think of people with a history of chlamydia as a high chlamydia prevalence group for which you should recommend regular screening beginning 3 months after treatment. How to acquire the retesting habit. As it is for screening and for EPT, setting benchmarks for practices in health systems is one effective way to approach this. Again, this opportunity is limited to certain settings, but you can use subsidized testing where available. And again, using systematic screening reminders such as smart sets and others that are programmed into the EHR have some benefit. And then Oregon reminders here too can be used, as well as text or other applications, texts that are generated directly from the electronic medical report. So let's review then in symbolic fashion. So chlamydia is really common, and it causes a lot of morbidity. That's costly. And 3 habits you can employ to reduce the impact of chlamydia are regular and systematic screening, expedited partner therapy, and retesting everyone who has a diagnosis of chlamydia in 3 months or within 12 if possible. So that's the end of my prepared remarks, and I really appreciate your listening. And with Becca's assistance and permission, I'm happy to entertain any remaining questions you all might have.
Thank you very much. And you went quickly through that last section. I thought I was trying to speed us up so we could have enough time. So we have plenty of time to take remaining questions. Again, please feel free to chat them in. Or if you would prefer to voice your question, you can raise your hand by clicking on the little hand icon next to your name. Dr. Schaefer, while people are still submitting their questions, I'm
Sure.
wondering if you have any experience working in clinics where they've done a fantastic job of actually improving their screening rates, and you know, have there been any initiatives that you've been a part of where you've seen people really improve and what they did to get there?
A couple of things I know. I think, you know, large health systems where, you know, there's a champion for an activity have an advantage. Kaiser in Oregon and Washington is one of those. They do a lot of expedited partner therapy for chlamydia and some for gonorrhea, and they have a number of infectious disease doctors and others who promote it. They use their electronic medical record to remind people about the use of expedited partner therapy, and yeah, it coincides with one of the other recommendations I suggested earlier about getting expedited partner therapy up and running, in that, you know, it has prominent support from the administration, so clinicians feel like, okay, this is a normal activity, and you know, my employers expecting me to try to think about this. So I think, you know, some of those ideas can be applied to smaller practices. I also know that Lane County Public Health Department made it a point to find some resources to purchase medicines for use for expedited partner therapy. And obviously, not every setting is going to be able to identify a way to subsidize expedited partner therapy, but in that case, they did, and having those medicines on site, I think, really increases the likelihood that they'll be used.
Thank you. Those are great examples, and I would encourage folks to look into those more. There, one of the questions that came in was about the recommended period of abstinence after treatment.
Yeah, we usually say 7 days. The medicines work quickly, so the person is not likely to be infectious at 7 days. So 7 days is pretty much a standard recommendation. I suspect it's even quicker that they're no longer infectious. With chlamydia, if you're going to retest for whatever reason, remember we said the test of cure for chlamydia is not really something you need to be doing. But if you think someone might have gotten reinfected, you should wait about 3 weeks. And that's pretty conservative, but there's some data that suggests that the NAT test detect residual biologic material from chlamydia that might give you a false positive test if someone was effectively treated before the end of that 3 weeks.
Perfect, thank you. And another question came in about what's the next first logical steps for folks who are on this webinar and they're going to take this back to their practice and start implementing this? What's the very first thing they should think about doing?
Well, I would say, and I didn't really say this in my talk, but my experience with things like this, system change, is that the intervention needs a champion in the organization or in the facility, and somebody who is passionate about it. And you can't always force that, but if there is somebody like that, or if you want to be that person, then things like systematic screening or use of expedited partner therapy are most likely to take hold. So, you know, I know that might be a pipe dream, but it's nice to have a champion at each place. I would say that for both screening, actually for all three habits, I think the next thing to do would be to try to have a conversation with the person or people who are the medical directors of your site, and try to get them to start thinking about written policies and suggestions to make it clear that the clinic organization that you work in is interested in seeing these things happen.
Perfect, thank you. We found the same thing to be true in the work that we do is finding a clinical champion, or even, I mean, finding leadership at all levels of the team to make sure that, you know, this gets moved forward, and remind yourself that this is, you know, it's about the patient. And
you know, we recently, I was telling you about data we got from the about retesting, and only 30% of women in these safety net clinics got a retest, and you would think those sites would be more likely to retest because they're participating in a chlamydia prevention program. But it turns out that when we talked to some of the sites, they just didn't have any policy or systematic method of thinking about retesting. And so I think, you know, sort of trying to figure out systematic ways to make this happen without having to have it be always something that the clinician themselves thinks of spontaneously every time.
absolutely, and there are resources for folks who are trying to write policies and procedures. I know the Oregon Public or Primary Care Association has lots of templates and resources because they've been working on this.
We'd be quite happy. We'd be quite happy at the STD TB program here at OHA to try to work with people on those. We haven't had that opportunity, but it'd be one we'd relish.
That's fantastic to keep in mind. So we'll stay in touch about that. We had another question in just a couple minutes to answer. Is there any funding from OHA to provide EPT medications to some clinics for patients who cannot afford the prescription? You mentioned Lane County found some funding to provide EPT, but is there any funding at the?
Yeah, this question it probably has sort of a hidden theme, and that is that the federal government subsidizes medicines for treating STDs. It's called the 340B program, and the state does get medicines through 340B. However, the federal government has so far declined to make it clear that it's legal to use those medicines for expedited partner therapy, which is a big disappointment to the people who run these programs. So that's one source that we hope will become available. It is not available yet. We've had discussions at our section about whether or not there might be some funds to help pilot this, but for the most part, OHA's funds come from federal government, and they're mostly for programmatic purposes, so we have very few funds to subsidize actual medicines other than the 340B medicines. We certainly have high hopes that you know, that public health will see increased funding with the efforts towards modernization that are ongoing in Oregon, and maybe this would be an area where we could expand our resources.
Thank you. That's a good clarification, I think, for folks. And we just have a couple more minutes, and I didn't see any other questions come through, but if folks think of things afterwards, they can email info@pcpci.org, and we can forward the questions on to you, Dr. Schaefer. But I want to thank everyone for their time this morning, early on a Wednesday morning, and ask you to please complete a short post-webinar survey. I think it's 4 or 5 questions, just so we can improve the webinars that we provide. And the next Primary Care and Public Health Series webinar will be November 17th on falls prevention. And the link is there. The slides are in the handout, but we'll also post the slides along with the recording of this webinar to our website, the same place you visited to register. And then we have also on the slides some resources that were mentioned and then some of the references as well. But thank you, Dr. Schaefer, so much for your time and expertise. This has been really enlightening, and thank you everyone for paying attention and asking such great questions. Anything else you'd like to leave us with?
Me personally, no. I appreciate the questions in particular. It's awfully strange to be talking to yourself in a room alone, so it's nice to know that somebody's listening.
Absolutely. All right, well, thank you, everyone, and have a great rest of your day.